Hi, I'm Peter Boland, and welcome to today's podcast. Today, we're going to focus on the Boston Medical Center, one of the country's leading hospitals that's been at the forefront of social care for decades. This remarkable case study and the lead example in the Health Equity Case Studies Handbook. It's a terrific read from start to finish. And the beginning of the story started years ago when a physician, Dr. Frank, realized that many of her patients didn't have enough food. So, being practical minded, she kept a store of canned vegetables in her desk drawer and gave them out to whoever needed them. And this was the start of the hospital's food pantry program. And it grew over time and eventually expanded to the top of the buildings and the first rooftop farm sponsored by a hospital. Today, BMC gives out more than 1 million pounds of healthy food a year, and the first food as medicine model in the country, and the first teaching kitchen, too. Now, there's also an AI stylized version summary of the case study also on our bolandhealthcare.com website. Right now, I want to talk about the key learnings of the detailed case study and summarize it from a typical patient's point of view as a way to humanize it and to tee up lessons learned for other medical systems and clinicians to consider. A BMC is at the forefront of so many social care programs that merits our attention. I hope you'll take the time to read the whole case study. It's a story of innovation, compassion, equity, and at the country's largest safety net hospital, and a model for putting health equity into action. Now, we can start with a typical patient named Martha, who is a 47-year-old immigrant, mother of two, living in nearby Dorchester. English is not her first language. So she drops by the food pantry every 2 weeks, picks up her order that's already been matched to her doctor's nutrition prescription. And for Martha and her diabetes, that means fresh vegetables, less sodium, and whole grains. And Martha also takes advantage of a free cooking class at the hospital's teaching kitchen, where she can learn to prepare affordable meals for her family, using ingredients from the pantry. Classes are taught by registered dietitians who tailor recipes to cultural preferences, and that keeps Martha's blood pressure under control. The vegetables come from the rooftop garden's 2,700 square feet of acreage over multiple sites, and that produces 7,000 pounds of fresh produce every year and cuts carbon emissions by half. Martha comes back every 3 months, fills out a simple one-page questionnaire that's available in 6 languages. It's called the Thrive Screener and covers things like food insecurity, housing, and even trouble affording medications. Now, if Martha checks yes, to worries about paying the rent, the system automatically prints out a referral guide about local housing resources and connects her to social workers right in the clinic. The integration of social determinants into everyday medical practice is what turns BMC from a safety net to an ongoing bridge to better health. And Martha's children also benefit since they're enrolled in Children's Health Watch. It's a program that studies how poverty, food insecurity, and housing stability affect child health, and how specific policies can fix it. BMC found that coordinating housing, legal aid, and health services cut the rate of poor child health by 32% in 6 months, which is an amazing finding. The hospital found that the medical legal partnership program helps families address issues at the root of poor health, from housing conditions to access to benefits. And another program called Street Cred offers free tax assistance to families during pandemic visits. I'm sorry, during the pediatric visits. I don't know if this started during the pandemic or afterward. But the result is that over 8 million is returned to families in a given year. And each of these programs are seen as medical interventions. And another intervention, the Violence Intervention and Advocacy Program, provides counseling, housing aid, and employment links for victims of gun violence, often right from the emergency room. Project Assert connects ER patients to addiction recovery and primary care, including naloxone kits. And one of the most frequently asked questions about local community initiatives is, how can hospitals influence the neighborhoods around them? So Dr. Megan Sandell, a BMC pediatrician leader of the Boston Opportunity System Collective, has a clear answer: by changing institutions, not people. And she points out that where people live, their zip code, often determines how long they live. We need to heal those places, not just the patients that live in them, she says. The truth is, healthcare doesn't start at the hospital. It starts at home and the neighborhoods around it. And Dr. Sandell elaborated much more on this topic, at the end of the case study, which again is worth reading. The Boston System Opportunity Collaborative's goal is to fill 500 good-paying jobs and provide 100 affordable housing units while helping families stabilize and thrive. So back to Martha. When she looks at BMC, she sees her hospital as more than a place for just tests and prescriptions. It's where she's learned to cook healthier meals, where she's found help paying rent, and where her children begin to grow stronger. We can say that place-based equity initiatives can start with a simple program like a food pantry, or a rideshare program to the clinic, or staffing a behavioral health clinic. Then it can build out from there and make a profound impact on families like Martha's. And with that in mind, I'd like to turn to a few BMC takeaways that address clinicians, and then follow that up with more takeaways focused on the C-suite and their responsibility to carry out more equitable care and more equitable community programs. So on the clinic side, consider these actions. Number one, consider equity in every visit. And that means treating every patient as a person, not just as a diagnosis, and about social needs like housing, food, safety, and then connect them to in-hospital and community resources to reduce preventable gaps in care. Number two, food and nutrition are central to health, not an add-on, but central. Food and nutrition are clinical care. Prescribing food as medical diagnosis helps manage chronic illness and reduces downstream costs. Number three, financial and legal support reduce toxic stress that fuels chronic disease. These programs reduce stress, prevent crises, and support adherence to treatment. Number four to consider, team-based care is going to be your safety net. So communicate frequently with nurses, social workers, pharmacists, and community health workers. Use huddles and brief check-ins to flag at-risk patients and make sure no one falls through the cracks. 5, lean on evidence, but adapt to your patient. Use evidence-based protocols and then personalize them to the patient's situation. And ask them what matters most to you, and then adjust the goals together, you and your patient. That's what clinicians routinely do at Boston Medical Center. Number 6, protect your own well-being and protect your patients too. Use early wellness touch points like primary care and brief wellness chats, and seek out peer support. If you feel burned out or overwhelmed, reach out. It's a sign of professionalism, not weakness. And 7, turn every encounter into a teaching moment. And that means modeling how to talk about health equity, social determinants, and shared decision-making for trainees and colleagues. And keep in mind that simple, everyday conversations shape the next generation of care. So now let's look at maybe 7 things for senior leadership and boards to consider that can be learned from the Boston Medical Center experience. First, embed equity into strategy, not just mission statements. Set measurable goals for reducing disparities by race, insurance status, zip code, then align performance metrics, staffing, and investments around those targets. Second, design systems that support clinicians, not overwhelm clinicians. This is critical for generating win-wins. And it means streamlining documentation, reduce redundant tasks, invest in clinical workflows, so clinicians can focus on patients. And use dashboards that are simple, timely, action-oriented. Third, build a proactive, not reactive, a proactive wellness culture. Integrate wellness into onboarding and orientation for all new staff. Normalize conversations about mental health and provide easy, stigma-free access to care and peer support programs. Fourth, empower frontline teams to drive change. That means giving clinicians and frontline staff resources and decision-making authority to pilot and spread innovation that improves safety, equity, and efficiency. And always celebrate small wins publicly. This reinforces staff morale and keeps on message. Fifth, screening for social needs must be embedded in clinical workflows like BMC's Thrive model. This is important to close gaps in care and coordinate services. The screeners must connect to real referral pathways and not just add to more and more documentation. And sixth, health equity demands addressing systems of disappointment, systems of disinvestment, and partnering with communities, not just serving them. This means power sharing, which in turn increases trust and long-term impact. And 7, reach beyond hospital walls. As a community anchor, invest in community health workers, housing, food programs, and partnerships with local organizations. That says to the community, the hospital isn't in it just as a treatment center, but a true partner in population health. All anchor institutions, not just hospitals, but all anchor institutions have responsibility to break the cycle of poverty in neighborhoods around their institution through place-based hiring, community wealth building, and even green infrastructure. And anchor institutions have a moral and economic power. I want to suggest, again, moral and economic power to drive community transformation. But it needs to be part of a generational commitment. And that means being all in for the long game. And that was noted a little bit earlier in a podcast with Nationwide Children's Hospital in Columbus, the commitment to the long game. Now, back to Dr. Sandell again. Again, institutions need to change, not people. So, it seems like such an obvious fact, yet some healthcare institutions have been slow to learn it. It's a basic principle of health equity and sustainable equity initiatives, and that's the key, sustainable equity initiatives. So the truth is, again, healthcare doesn't start at the hospital, it starts at home and the neighborhoods around it. So I hope that covers some of the main learnings from Boston Medical Center case study. I hope this summary begins to capture how much Boston Medical Center can teach us. Thank you again for listening to More Health, Less Healthcare today. I'm Peter Boland.